My topic is a little bit more basic. I would say I will talk about classification of colorectal polyps, how to be pragmatic. And first of all, I want to tell you and show you a couple of nice images, because polyps remind me of an island that nicely are raised from the sea surface, as polyps are raised from the colonic mucosa. They can be very smart, they can be very big, they can be pedunculated, flat, or sessile. They can be of various shapes, like these beautiful islands in Croatia, or they can be of a more uniform surface pattern, or maybe different areas, or depressed. And what we actually want to know is how actually they go deeply to the colonic wall. So they are mostly asymptomatic. That's a problem, but on the other hand, they may cause bleeding, they can cause a tenesmus, they decrease the stool caliber, and they can cause diarrhea or constipation or bowel obstruction. And, but why do we need for search for the polyps and colorectal lesions? The final aim is to prevent cancer mortality and morbidity. And we know actually that cancers are raised from polyps, from adenomas. We know this from adenoma to carcinoma sequence, and also there are serrated lesions that are actually, in a way, new kids on the block. We know much more nowadays about them, and we are familiar with serrated neoplastic pathways, and we know that sessile serrated adenoma are responsible, according to the literature, for up to 35% of colorectal cancers, many being interval cancers. Risk of carcinoma, we know from the old data that increases with the size of the polyp, and also increases with the type of the lesion, being the highest with the type C lesion of Paris classification. And also with laterally spreading tumors, we know that the non-granular surface actually is connected, especially the depressed one is connected. Almost all those lesions will be cancers where they are large. So first, before classifying polyps, we have to find them, and there are lots of variables around it. So endoscopist experience is very important, but bowel preparation is very important. So withdrawal time, rectal retroflexion, what kind of equipment do we have? Do we use high definition scopes? Can you use virtual chromoendoscopy, which is actually marginally better for detection itself, but we need it for the classification of the polyps. So wide angle scopes, transparent cap, fold flattering devices, and new imaging modalities included computer-aided detection. And these variables actually are opportunities for quality improvement. If we want quality, we have some goals. Our adenoma detection rate goal is, like, we want to discover adenomas in at least 30% of our screening colonoscopies in men, and at least 20% of screening colonoscopies in women. And we know that we actually miss these lesions, and we have parameters for this: adenoma missed rate and advanced adenoma missed rate. And this data is also in the literature, and this is actually why these interval cancers occur. So once we find the polyp, we can systematically approach to the polyp. We have to speak, of course, of the location and the size, and then we go to classification. We have to morphologically classify the polyp, and then use some advanced, I would say, classification methods, like using chromoendoscopy, like nice Janet classification, and we can describe Kudo's surface pattern, and all this in order to make a diagnosis and to plan what to do with this polyp, to plan resection method if we were to resect, and then to plan whether we are going to send this specimen to pathologist or not, and then finally to plan a surveillance colonoscopy. So it's easy when you have a polyp in the cecum or in the rectum. In other parts of colon is more difficult. We can use a length of the insertion of the scope, and don't remember that you can use tattooing for marking the lesions that are that is hard to detect, or that you are not able to, especially the ones that are not able to resect, and you are going to send it to another expert or to a surgeon. Then the size, so we speak about diminutive polyps if they are 1 to 5 millimeters, and we speak about small polyps if they are 6 to 9 millimeters. And then we have, of course, big polyps. And finally, we come to morphology, which is very important, and surface pattern that we need to look at. This is actually really what we are going to speak about today. So this is the example of two, I would say, almost kissing polyps in rectum in one of my patients. And you see that they are definitely different. You see some regularities here, and you see this polyp. So after tummies, this one was adenoma, and this one was invasive cancer. So we have to be able to predict this before, and then to decide what to do with the polyp. So first, morphology. We use Paris classification that was developed in 2002 and updated in 2005. And we speak about polypoid protruding lesions, so pedunculated polyps, sessile polyps. And then we speak about non-polypoid, non-protruding, so flat or superficial lesions, and then can be 2A is flat elevated, then they can be completely flat, like 2B, and then superficially depressed 2C. There are some combinations of this, and also they can be excavated. So in this group, particularly in this group, there is a high chance for a cancer. This is just a sample of a flat lesion, of a pedunculated lesion. You all see this kind of lesions in your everyday practice. When you have a flat elevated lesion that is more than 10 millimeters in diameter, and the height of the lesion is less than half of the diameter, then we speak about laterally spreading tumors. We have basically two groups. We have LST granular type and NST non-granular type, and granular type can be homogeneous. When you have like a homogeneous surface, homogeneous granularity, and LST granular nodule mixed it when you have some nodules that are really obvious when you see them endoscopically. And then non-granular type, we have flat elevated and non-granular pseudo-depressed. This is an example of a granular type LST. You see some rather uniform granularity here, but definitely you see some nodule here, so this would be LST granular mixed type. And for example, you cannot really say here that there is some specific really nodule, so this is like a granular type of LST lesion, and this is a non-granular type of LST lesion. And you see this area here. It could be that it's a pseudo depression, but you have to know that you always take very good images, inspect this for some time to see whether this is because of this lesion is on the fold, or if this is really a pseudo depression. And we have to add some more. So this was morphological classification, but we need to add some color so that we can get some extra features of the lesion, so that we can properly classify and then to decide what to do with this lesion. So the first one to mention is very famous NICE classification, so MBI classification, narrowband imaging. And in this classification, so we look at the color, vessels, and surface pattern. We look at the color, vessels, and surface pattern, and according to these three features, we speak about hyperplastic, so type 1 lesions. Then we speak about adenoma, the type 2 lesion, and deep submucosal invasive case, that's like type 3 lesion. So the type 1 lesion, so the color is same or lighter than the background, and for the vessels, there are no vessels, or there are isolated lacy vessels that are crossing the lesion. And for the surface pattern, there is a white or dark or white spots of uniform size, and the most likely pathology, as I said, is hyperplastic. In type 2 lesions, they are browner relative to the background, and brown vessels are surrounding white structures that can be oval, tubular, or branched, and this is a typical adenoma, so a nice type 2 in nice classification. And finally, nice type 3 is these lesions are brown and darker brown relative to the background, and sometimes they have patchy whiter areas. They have areas of disrupted or missing vessels, and also they have amorphous or abscess surface pattern, so these are deep submucosal invasive cancers. So this is one of the examples. So this polyp is browner relative to the background, and brown vessels are surrounding white structures and that are tubular, more like branch white, and this is then, according to NICE classification, this would be a nice 2 lesion. Another classification comes from Japanese MBI expert team. Japanese do a lot more ESDs, and then they wanted to have, on the one hand, a rather easy classification, but that can offer them more information than NICE classification. And in this classification, they look at vessel pattern and surface pattern, and they have 4 groups: type 1, type 2A, type 2B, and type 3. In type 1, there are no vessels, they're invisible, and there are regular dark or white spots, and similar to surrounding normal mucosa, and this is hyperplastic polyp or sessile serrated polyp. In type 2A, there is a regular caliber and regular distribution of vessels, and there is a regular surface pattern which could be tubular, branch, or papillary, and these are low-grade intramucosal neoplasia, whereas in type 2B, there is a variable caliber of the vessels and irregular distribution, and there is irregular or obscure surface pattern, and this corresponds to high-grade intramucosal neoplasia and shallow submucosal invasive cancer, but they didn't need this group because they can sometimes try to remove it by ESD and then get the perfect, I would say, biopsy specimen to analyze and to decide how to manage this patient afterwards. And of course, type 3 lesion, which is not for endoscopic resection with amorphous areas, loose vessels areas, interruption of thick vessels. This is another example with a regular surface pattern, regular caliber, and regular distribution distribution of the vasculature, and this is JANA 2A type. So even before these classifications, Professor Kudo in 1993 actually proposed the Kudo classification. He could describe normal crypts on the other hand, and he could actually look at the surface pattern, and then he actually ended up with 6 groups. In the second group are serrated polyps, and the 3S group is tubular adenoma. You see here the surface pattern, and then tubular adenoma. There is a 3L group like here, and there is a tubulovillous adenoma with like branch-like structure, and finally malignant polyp with no regularities. So this is Kudo pit pattern that we can use, and many actually use it and describe it for polyps that they found. Again, the same polyp Kudo classification, branch-like surface pattern. So this is Kudo 4 classification. So sessile serrated lesions, as I said, new kids on the block, they're responsible for up to 35% of colorectal cancers. They are difficult to detect, they're more difficult to delineate, and they're more right-sided. And we miss them to a slightly a bigger extent than adenomas, but this is probably underestimated. And they're really easy to miss, so take your time, don't withdraw your scope too fast, because you can miss lesions like sessile serrated adenomas. The problem with nice classification, Janet classification, is that actually they weren't look at sessile serrated lesions, sessile serrated polyps, and there was a Dutch group, work group of serrated polyps and polyposis that actually proposed the classification that combines nice classification and endoscopic features for sessile serrated lesions in a stepwise approach. And the aim of this classification is to accurately discriminate between hyperplastic polyps, adenomas, and then sessile serrated adenomas or polyps that are smaller than 10 millimeters. And the potential benefit, if you can do it accurately, is that you can lower the cost for workload for pathologists and also for gastroenterologists if you decide to resect and discard on one hand, or if you decide for leave-in policy. And what they actually did is that they looked, so MBI characteristics of the polyps, so the color, the vessels, and the surface pattern, and then they said, okay, we have type 1 polyp or type 2 polyp, but then I applied a criteria for sessile serrated lesions, so clouded surface, indistinctive border, irregular shape, and dark spots inside the crypts. So if this character 2 of these following features were present in either type 1 or type 2 polyp, this was considered to be sessile serrated adenoma or sessile serrated polyp, and and then you have adenoma and hyperplastic polyp. And this classification was very good, and they could achieve 91% of negative predictive value for optical diagnosis for diminutive neoplastic lesions if the endoscopist was diagnosed this with high confidence. And this is actually very good results, and based on this we could actually, some of the hyperplastic, especially hyperplastic polyps, for example in rectosigmoid, we could leave them, not to resect them, and maybe some other lesions to dissect them and not send them to the pathologist. And so about resect and discard and leave-in policy, so it's what's interesting, and ESG in the guidelines that were published this year actually addressed this, and they said, okay, diminutive polyps that are 5 or less millimeters account for approximately 60% of all polyps, and they're very low risk. There's very low risk of cancer, and there's a potential benefit that was mentioned before if we resect it and discard it, or even if we leave it in. But the statement says that ESG suggests that virtual chroma endoscopy and dye-based endoscopy can be used under strictly controlled conditions for real-time optical diagnosis only of diminutive polyps, colorectal polyps, and can replace histopathological diagnosis. The optical diagnosis has to be reported using validated scales, must be adequately photo-documented, and can be performed only by experienced endoscopists who are adequately trained as defined by ESGE curriculum and also audited. So it's not that everybody can start from tomorrow to use these policies. This is just one of the examples of a lesion that has some mucosa that is yellowish, and so even if you have, especially if you have a good colon cleansing, if you find something like this, I suggest you to wash this, because you have to know what is under this, and this could be easily missed. And then to conclude, when we speak about polyp classification, we have to speak about size and location, and there are various classifications. The combination is required. I suggest, and the literature suggests, always to use Paris and the LST classification depending on the lesion that you have. And then you have to use some, nowadays, mostly virtual chroma endoscopy, so you can use a nice classification or Janet classification, or you can consider using WASP classification, and you can describe a Kudo-Pitt pattern. And all this classification is to decide the best management for both patients and healthcare system. So we need to decide whether we are going to resect the lesion or we are going to leave it in. And if we are to resect the lesion, how are we going to resect? And are we going to send it to pathologist or we're just going to discard it? And on the surveillance, on the side on the surveillance. And the last slide is maybe just to briefly conclude with which lesions not to resect or which lesions should be sent to the expert center. So depressed part is 2C lesions, LST non-granular, especially pseudo-depressed. Of course, pseudopete pattern fine, nice type 3, but with Janet, type 3 of course, but with 2B probably should be sent to an expert endoscopist. And there are some other characteristics like ulceration of the lesion, induration, and non-lifting sign if you plan to resect the lesion if that doesn't lifting. So probably you should think what are you going to do and how are you going to proceed. And finally, always think of that you can send the patient to the expert center. Don't biopsy lesions if you are planning not to resect it, and send it to some other endoscopist. Thank you very much.